To move on now to our first debate of the day. We've got 3 debates today, which we're hoping will result in us solving all of your unanswered questions in myeloma and all the controversies and uncertainties. We're going to start with a case, which I'll present, and then I'll introduce our 2 debaters. So this is a 69-year-old delivery driver presenting with a significant past medical history, cardiac disease. You can see the type 2 diabetes, which is diet controlled, and a pre-morbid performance status before this diagnosis of somewhere between 0 and 1. Presented with a 4-month history of constipation, a 3-month history of pain in the back and the arm, and came into the clinic to receive the diagnosis in a wheelchair because of the pain. But no focal neurology, struggling to sleep, but otherwise no other significant symptoms other than what we can see there. And was given the diagnosis of myeloma with an IgG lambda paraprotein of 23 grams per litre. You can see there high kappa-lambda ratio with kappa sitting at 100, so not a huge light chain burden, but high corrected calcium, acute kidney injury with an EGFR of only 23 and baseline of 60. Anemic with an ISS of 3, as you can see there, and the bone marrow reported as showing sheets of plasma cells, approximately 80%. And on FISH, no IgH rearrangement, but the other analyses failed. Imaging showed a right paraspinal, locally invasive lesion, fairly destructive, as you can see there, and then extensive lytic lesions at a number of sites, especially in the sternum and in the vertebrae you can see there. So that's our case, and we've been given these options, so hopefully this is going to be your first opportunity to successfully vote. I don't know if we've got the voting page there yet. We've got a thumbs up. So you should be able to vote here and online as well. Here are your options. So you can give some initial resuscitation and then optimize the renal function and decide what you want to do. Or you can go straight in with induction therapy, thinking about proceeding to transplant, or think about a non-transplant eligible pathway, either with DRD, or you can see there the Velcade-based triplet, consider a clinical trial, or we've given you the get-out clause of other, which I don't think you should vote for, but you can if you want to, if you feel that something's not represented that you'd like to say. So I don't know, we'll give things another 5-10 seconds. I'm sure the technician will know how much more.
Yeah, give it a little while so people can log in here and online as well. Thank you.
Okay, so I'll give you a few more seconds to consider that. Okay, so let's see what people have decided. Okay, so almost half of you have decided to wait on that decision between transplant eligible or ineligible and see where the patient gets to once they've been optimized. Perhaps we were a bit kind to give you that as an option, actually. We should have forced you down another option. As you can see there, a large minority then have gone down the transplant eligible arm, and then just under 10% of people have gone for the DRD arm. So interesting, we'll see whether that changes. We're hopefully going to be able to vote on that afterwards. But I'm going to introduce now Kerry Bygrave and also Guy Pratt, who are going to solve this problem for us. They're going to debate whether or not we need frontline transplant in myeloma at all anymore. And hopefully will tell us what the latest evidence shows about that. Kerry's going to argue for. She's a consultant haematologist, clinical lead for myeloma at the University Hospital of Wales in Cardiff, chair of the UK Myeloma Society and a member of the UKMRA. And I'll introduce Guy before he comes up to defend himself. He's a consultant haematologist in Birmingham with a clinical and research interest in myeloma and Waldenstrom's, CLL, and plasma cell disorders such as amyloid. And he's professor of haematology at the University of Birmingham. And between them, they're going to battle out this decision. So thanks to you both.